you. Dr. Helen Dickens, who was the first black woman admitted to the American College of Surgeons. Now, as I just said before, Dr. Daniel Williams was the first male to be admitted to the American College of Surgeons, and I believe Dr. Dickens came right after him in that feat. Now, she earned her medical degree from the University of Illinois in Chicago in 1934. She completed her internship at Providence Hospital in Chicago, which is the hospital that Dr. Williams actually founded. And she, during this time, treated patients with tuberculosis in impoverished communities. In 1945, Dr. Dickens was the first black woman to receive board certification in my specialty, OBGYN, or obstetrics and gynecology. 5 years later, she became the first black woman admitted as a fellow of the American College of Surgeons. She served as director for the obstetrics department at Mercy Douglas Hospital in Collingdale, Pennsylvania for more than 12 years. Dr. Dickens, I salute you. Dr. Patricia Bath was the first black female physician awarded a patent for a medical invention. Dr. Bath received her medical degree from Howard University College of Medicine in Washington, D.C. She interned at Harlem Hospital in New York City from 1968 to 1969 and completed a fellowship in what is happening with me today? Ophthalmology, at Columbia University from 1969 to 1970. Dr. Bath's accomplishments included the invention of a medical device and technique for cataract surgery known as laser phaco, for which she was the first black woman to receive the medical patent. She was the first woman appointed chair of ophthalmology. Babe, can we stop that for a quick second? Go back. Let me read. Let me do her again, please. Can you spice that out?
I like to eat apples and bananas. I want to eat apples and bananas. I need to eat apples and bananas. Why can't I eat apples and bananas?
One in 5 children struggles with hunger in America. Support the Feeding America.
Awkward. Do I look familiar? I should. You might remember me from here. Here. Or maybe even here.
But an awkward silence can be a great thing.
It can actually be a perfect moment to reach out to a friend and ask if they're okay, if they seem down.
It doesn't matter how you say it.
You alright?
Everything's okay?
All G?
You alright, girl? You cool?
You bugging dog.
Just show you're there for them. Go on, Kelly. Seize the awkward.
Hey, you haven't really been yourself lately. Are you okay?
Find out how you can help a friend with their mental health at seizetheawkward.org. How to know if you should reach out to a friend. Your friend might be.
Dr. Patricia Bath is the first black female physician awarded a patent for a medical invention. Dr. Bath received her medical degree from Howard University College of Medicine in Washington, D.C. She interned at Harlem Hospital in New York City from 1968 to 1969 and completed a fellowship in ophthalmology at Columbia University from 1969 to 1970. Dr. Bath's accomplishments include the invention of a new device and technique for cataract surgery. This is what she received her medical patent for. She was the first woman appointed chair of ophthalmology at a U.S. medical institution, which was UCLA, in 1983. Dr. Bath retired from her post 10 years later and has since become an advocate for telemedicine, serving in roles related to the emerging technology at Howard University and St. George's University in Grenada. Dr. Bath, I salute you. And the final one is Dr. Jocelyn Elders, who was the first black female appointed Surgeon General. Born to a family of impoverished farmers in 1933, Dr. Elders grew up in a rural, segregated pocket of Arkansas. In spite of socioeconomics and obstacles associated with that, she earned her medical degree from the University of Arkansas School of Medicine in Little Rock in 1960. She returned to the university for her residency the following year in 1961. After which she became chief resident, responsible for a team of all white male residents and interns. Governor of Arkansas at that time, Bill Clinton, appointed Dr. Elders director of the Arkansas Department of Health in 1987. As U.S. president, Mr. Clinton appointed Dr. Elders as the first black U.S. Surgeon General in 1993. Dr. Elders, I salute you. I am here as a black female physician because of them. I am so blessed to be amongst them. I will be happy to see the day when we don't have any more firsts, but unfortunately in 2019, we still have a lot of firsts to accomplish. Until then, I will continue to honor and celebrate each of these trailblazers long after Black History Month is over. Because for me, it's not over. I'm Black 365 days a year. So I will continue as long as I can, for as long as I can. Every week, I have decided now to highlight a different trailblazer in the medical field. They may or may not, be African American, but people that have made an impact on the medical field. So who will I highlight next week? Stay tuned. You may know that person. Now, we're going to take a quick break. When I come back, I'm going to actually introduce my guests. I have one in-studio guest and one by phone. And we're going to dive into tonight's topic of discussion, eating disorders. We'll be back shortly.
Hey guys, I am Tyler Posey, and I am going to be sharing a personal story of mine with mental health and just kind of dealing with awkward silences and friends helping me out through it. Almost 3 years ago, I lost my mother to breast cancer. She was just there for me more than anybody, and I would go to her for everything. And then when she died, I felt like I didn't really have anybody to go to. I think humans need to break down and cry every now and then, and I would do that with my mom, and then after she died, I felt like I had no one to do that around. My friends, I gotta be tough in front of my friends, in front of my brothers, in front of my dad. I would go to work, and then I would go home. There were a bunch of times where my best friends would hit me up, and if I, wasn't looking so well or doing so well, they would bring it up and be like, hey man, are you okay, what's going on? I'd be like, yeah, I'm okay. I wouldn't really get into it. And I realized that, that didn't make me feel any better. When I get depressed, I feel like I'm a burden on people, and I don't want to burden them with my problems. And so once I got over that, I was able to open up more with them, and we just have these great deep conversations now whenever we're feeling sad. I even have a tattoo. It's a tattoo of 2 hands shaking like this, and it has a lot of different meanings, but to me it means literally to reach out to my buddies when I'm in need of them. If you know somebody well enough, it's kind of easy to tell if something's a little off. One of my buddies just recently has been going through some stuff. Whenever I would have a party, he would kind of isolate himself in the back and just kind of, I could tell that he was down. Sometimes I try to let him come to me first and see if he wants to, ask for help or say, hey man, I'm kind of low right now. But if he doesn't, I'll usually reach out to him. It's always kind of awkward to start that conversation. But now I think we've gotten comfortable enough with it, and I've seen the good that it does, so I try to get rid of that awkward feeling and just kind of go right for it. It's easy to forget that reaching out to your friends really kind of almost immediately makes things better. Therapy is something that I discovered a few years ago, then I started doing it a lot, and I'm a huge fan of therapy. I kind of use myself as an example. I say, hey man, I've been to therapy and it works, and just talking your feelings out, getting everything off your chest, that's therapy in itself. If you recognize that a buddy is kind of struggling, or you yourself are, I know how hard it is to reach out for your own reasons. I had my own reasons why it was hard. Just do it. It is kind of an awkward situation and not the most natural, but I think we have to get over that and make it a really natural situation. So just do it. Just kind of face your fears and ask somebody. It'll save a life. Save mine. Hey guys!
We are back, and it is Eating Disorders Awareness Week. It starts February 25th and runs through March 3rd, so we're right in the middle of it. And there are so many myths that are surrounding eating disorders that I had to bring people in to help me try to dispel those myths. You know, we're going to talk about what is an eating disorder, why does it occur, and who does it affect, amongst other things. You know, when I think of eating disorders, I think of Karen Carpenter. I don't know if you all remember Karen Carpenter, but she was a singer and drummer in the group The Carpenters along with her brother. And I remember watching a movie about her, and the movie highlighted her eating disorder, which was anorexia. And she ultimately succumbed and died as a result of heart failure due to her repeated use of vomiting medicines. And so, you know, to help me break down not only what anorexia is, but all the other eating disorders, I've got two guests with me who are very knowledgeable about this disorder. I have sitting right next to me, Joy Sebekindu.
That's it?
Yeah, I got it.
It's a tongue twister.
Yeah. She is a licensed professional counselor who graduated from Vanderbilt University with not only her BA in sociology and child development, but also her master's of education in clinical mental health counseling. Joy comes with over a decade of experience in working with children, adolescents, adults, and their families who have issues with communication, family transitions, including divorce, trauma, depression, anxiety, and disordered eating and eating disorders in general. She joined the Center for Discovery team in November of 2016 as initially the primary therapist for the Atlanta House. There's a lot of different branches for the Center for Discovery Health, but she's here at our local Atlanta House. And now she is program director for the Atlanta House. Joy also maintains an outpatient private practice in Atlanta, Georgia. To date, Joy is sought out by advocacy groups and mental health and treatment centers and hospitals to consult on multicultural cases due to her personal and professional experience in managing issues related to diversity, inclusion, and other issues related to ethnic sensitivities. Welcome, Joy.
Thank you.
And I have on the phone all the way from New York City, snowy New York, I've got Ms. Claire Miskew, who is the CEO of the National Eating Disorders Association. Claire is an award-winning author and internationally recognized expert on body image, leadership, and media literacy. Her book for girls, You're Amazing, a no-pressure guide to being your best self, was named to the Amelia Bloomer list, a project of the American Library Association that recognizes outstanding feminist books for young readers. She is also the co-author of Does the Pregnancy Make Me Look Fat? The Essential Guide for Loving Your Body Before and After Baby. Claire is a sought-after speaker and consultant who works with educators, organizations, and companies that want to reach girls and women with empowering messages. She has served as the director of the American Anorexia Bulimia Association and has held senior positions at Smart Girl and Girls Incorporated. An experienced professional skilled at inspiring audiences to take action for personal and social change, Claire has developed national media campaigns, acclaimed outreach programs, and pioneering online communities. Claire has appeared in numerous national media outlets, including 2020, Fox News Channel, the New York Times, and the Wall Street Journal. And now, Health Tips with the Nation's Bedside Doctor on Clark TV Network.
I'm going to add that one to the list.
That's right,
Thank
add
you
that
so
to
much.
the list. She has received her MA in Gender Studies from the New School for Social Research. Welcome, Claire.
Thank you so much for having me. I'm thrilled to be here.
Absolutely. I know it's all snowy down, or shall I say up in New York. It's rainy down here, so it's no better than that.
Well, in New York, it turns to slush pretty quickly.
I know, it sucks. I grew up in Cleveland. I used to hate the slush. So let's start breaking down what the eating disorders are. What are eating disorders, Claire?
Well, eating disorders are very complex illnesses. They affect 30 million Americans. 30 million Americans at some point in their life will struggle with an eating disorder. And when we talk about eating disorders, we're talking about a really broad range of behavior and diagnoses. As you mentioned before, anorexia is an eating disorder. We also see bulimia, which is characterized by binging and purging, and binge eating disorder, which is actually more common than anorexia and bulimia combined. But it is a newer diagnosis that was added to the Diagnostic Statistical Manual just a few years ago. So, we're starting to really hear more about how widespread eating disorders are. And at NIDA, we run a helpline, and we hear from so many people who are struggling with these issues, and yet they wait a long time to reach out for help. They're feeling a lot of shame. Eating disorders are very closely linked to other psychological issues, anxiety, depression. We see a strong connection with substance use. Many people with eating disorders also have past histories of trauma. So there are a lot of intersections with eating disorders and other mental health disorders. And then there's a lot of compelling research to show that there are biological roots. Some people may be genetically, biologically predisposed to developing eating disorders. And then, of course, we live in a culture that is obsessed with perfection and obsessed with fitness and thinness. And so, a lot of the thoughts and behaviors around eating disorders are actually validated in our larger culture. So these are complex issues, but we do believe recovery is possible. And I really appreciate you having this topic and covering it and talking openly about it, because we need more awareness.
Absolutely. So going back to body image. So this morning I was looking at TV briefly, and I heard a story that was very troubling. I heard a story about a high school in Wisconsin. It's what's it called? Trempler High School, where the cheerleaders at a awards banquet got these kind of awards like Big Booty Judy and Big Booby Stroob and String Bean, and the coaches thought that this was funny. They thought that this was a funny way, I guess, to call out their cheerleaders. And I don't see anything funny by it. The ACLU actually has stepped in now, and I believe that they are filing a lawsuit against the school system, and for good reason. This cannot go on, as far as body shaming. What are your thoughts on that? I know that you may not have heard about the story, but just in general, what is your thought on this?
Yeah, well, this is a great example of how toxic body shaming can be, and and a lot of times, as you mentioned in this story, this kind of stuff gets dismissed, or it's just a joke, or it's just fun, trying to be funny. And in fact, we know that over half of teenage girls and nearly a third of teenage boys are using unhealthy weight control behaviors and feeling a tremendous amount of pressure around body image. And so this is a serious too. And it's something that's unfortunately very widespread in schools. We work with a lot of high school students and college students who talk about how damaging kinds of comments are, and the focus on again, having the perfect body, or shaming those who don't fit that typical picture. So and there's a strong connection with eating disorders. Certainly a lot of people who struggle with eating disorders are also really caught up in a feeling of shame about their body weight and shape and size. So it's something that we really need to take seriously.
Absolutely. Now, Joy, what are the statistics? Why am I tongue tied today? I have no idea what's happening with me. As far as gender and race and socioeconomic status, what are you seeing in your practice?
Yeah. I wish we had more statistics on this, and Claire, I would love for you to jump in, as your organization is really heavy and deep with collecting a lot of this data. But most of the research on eating disorders is done on white women. We have to think about who is seeking treatment, who has the resources to do so, who has the support, the family, the cultural support to be able to do so. And so what we do know is that eating disorders doesn't discriminate. It affects all people of all ages, all sizes, all colors, all backgrounds. And I think we do have to do a better job of increasing the awareness as well as the access to care, so that everybody, you mentioned kind of social economic status, like we're able to provide those resources for treatment. Claire, I would love for you to kind of plug in and.
Sure. Well, I would echo what you said in terms of statistics, and knowing that these are illnesses that affect people of all demographics, and yet we still have this persistent myth, a typical stereotypical picture of who struggles, which is a young, white, affluent, thin woman, and that just does not reflect the reality.
Come from? Do you know where that myth
of who struggles?
Where did that come from?
I think and you can speak to the story, but I think you alluded to this, in that, a lot of the research on eating disorders has been done on white women. We have a lot of work to do, even within the eating disorders field, and, having more clinicians of color, more clinicians with a broader representation of the experience of people. And we also just have to start elevating stories that don't fit that stereotypical narrative.
Absolutely.
We need to see more faces. We need to hear more stories. And again, the myths about who's supposedly supposed to be struggling with eating disorders. It's a big barrier for people to reach out for help, because people who are struggling are not seeing themselves reflected in the coverage of eating disorders, which is why I think it's so wonderful that you're raising this topic and talking about it, because we've got to do more of that.
Absolutely. So there are so many different types of eating disorders. Most people only know of anorexia and bulimia, but let's go through all of the eating disorders if we can.
Sure.
Joy, what is anorexia?
Anorexia, they actually, with the new DSM, actually split it out. So we do have anorexia nervosa restricting type, as well as binge purge. And both of those designations do have to include a level of restriction. There used to be more qualifiers around that, but what we are recognizing is that it looks different for every person. And so what we are taking into consideration is a person's height, weight, cultural background. There's so many other demographics and intersections that we have to look at when we are trying to quantify what restriction is. We also see a distorted body image, and as we were talking about before, as a cultural presentation, it's not always this ideal that someone wants to be thin. Depending on the different communities, particularly those communities that have food as a scarce item, body image could be different, or the ideal of body image could be very different. And we're also kind of looking at this intense fear of gaining weight. So very similarly, whether it be restrictive type or binge purge, we are looking at the motivation behind what someone is doing to manipulate their food, or the eating disorder behavior, whether it be binging or purging as well.
Yeah. Hey, Claire, what's bulimia?
Well, bulimia is an eating disorder that's characterized by binging and purging. So when we talk about binging, we're talking about, in some cases it can be large quantities of food, but a binge doesn't necessarily have to be that. What we talk about with binging is really the shame that's associated with it. So if you're eating and then feeling a tremendous amount of shame afterwards, and then there's the compensatory behavior that can be through vomiting, laxative abuse. We sometimes see people who are using exercise as a form of purging. So it is a very serious eating disorder, as with anorexia and with binge eating disorder. But it's that binging and purging that we talk about with bulimia. And I'll also add, we alluded to how eating disorders affect all demographics, and that also includes size. And when we talk about anorexia, we are seeing many cases of atypical anorexia where people in higher weight bodies are actually engaging in extreme restriction. And with bulimia, you cannot tell by looking at someone with any eating disorder, really. So that's really important. It's not always focusing on the weight and the numbers on the scale can be really problematic because we're seeing disorders affecting people of all sizes.
I agree. It's multifactorial. Now, I will give us a couple of statistics, and with anorexia, it seems to affect 0.3 to 0.4 of young women and 0.1 of young men who will suffer from this. And can we talk about some of the characteristics? We said that, it's not just about weight loss or weight gain. What are some of the other symptoms that we may be able to see in anorexia?
Well, I think with all eating disorders, you want to pay attention to the behavior and really acknowledge that the eating disorder is not just about the food or the eating behavior. That's a coping mechanism to deal with other things that are going on. So you might see weight loss, but one thing to really pay attention to with eating disorders is how is the person behaving? Are they avoiding social situations because they're afraid to be around food? Are they exercising when they're sick or missing out on opportunities to engage with life and really retreating? Those are the kinds of things to pay attention to. And then of course oftentimes there is an obsessive focus around food, people starting to remove entire food groups or, be very, very rigid in their, approach to meal times. So those are some warning signs. But I think overall, I would encourage people to think about eating disorders as, the behavior is a coping mechanism to deal with much deeper issues that are going on.
Yeah, and we'll talk about that a little bit later on. What some of the comorbid conditions that can occur as a result of that. But some of the physical conditions that I've seen in patients, they can have brittle hair, nails, bones. If you see somebody that has a lot of unexplained fractures for whatever reason, it could signal that. Menstrual irregularities, and this is how I actually diagnosed one patient, was through mental irregularities. They have a decrease in their concentration. And they can have other GI issues like constipation. Pretty much it's because of the fact that your body is not getting enough energy to fuel the metabolism working right. So you then don't get enough hormones produced to make everything work properly. And so that's, some of what I've seen. Also, with anorexia, because there is a vomiting component to it, we'll start to see some erosion in the teeth. That can be because of the repeated vomiting, and the acid that's from the stomach is wearing down that enamel. And death can happen. As I said with Karen Carpenter, her heart stopped. And it's because your heart is a muscle. And so when you are in that starvation mode, what does your body want to do? It needs to get fuel from somewhere, and the first place it's going to grab it is a muscle. And unfortunately, the heart has to suffer as a result of that. So that's why it's very, very serious when somebody has an eating disorder.
Yeah.
And eating disorders actually have the highest mortality rate of any psychiatric diagnosis.
So they absolutely
these are very serious illnesses.
I often hear from parents, you know, Center for Discovery in Atlanta is an adolescent facility, and so I oftentimes sit with parents before their adolescent enrolls with us, and they are all just so saddened by the fact that they didn't see it coming. And they kind of mentioned times where, you know, some of these behaviors, like you mentioned, Claire, a lot of dieting behaviors and exercise and movement can be good in moderation. And what they often see, and I actually had a family describe this to me, that, hey, we just thought our child just wanted just to be aware and healthier. So she started walking, and then it started running, and then the running became more and more. And so those are just warning signs that I hear from parents a lot of these little behaviors become a lot bigger as the disorder develops and deepens.
Absolutely. So Claire, you mentioned it. Go ahead.
Well, I was just going to really underscore the trusting your instinct as a parent or a loved one. If you're getting an inkling that the behavior is becoming obsessive, that's a really enough of a warning sign to reach out for help. And we know that early intervention makes a huge difference in treatment outcomes. So, you know, if you're having that feeling that your child or someone you care about is going down that path, reach out for help early. And dieting is a major risk factor. For eating disorders. And, you know, again, when we talk about the larger culture, we have so much emphasis on health and wellness. You know, there's a lot of focus on obesity prevention in schools. And what we're finding is that, you know, sometimes this, you know, emphasis on the scale and BMI and weight loss can be very triggering. And, you know, a lot of parents and kids cite those kinds of programs, not as the cause of their eating disorder, but as a beginning point where they started to become very focused on it. So we have to, as a culture, start thinking about how we relate to health in a more holistic way. You know, that weight alone is not an accurate measure of true health.
I agree. And what I was going to say, actually, you said most of it, but, you know, it probably starts off innocent. And then it just spirals downhill because, you know, you become obsessed with what you think you should look like or what you should feel like. And here we are with eating disorders when it happens. So you also mentioned, Claire, about binge eating, because that is one of the newer of the diagnosis. And we described what binge eating was. You're eating large volumes of food in a short amount of time, and then you start, you know, feel shameful that you've had this large food. So then what do you do with that?
Well, with binge eating disorder, we don't see the compensatory behavior of the vomiting. But I will say that binge eating disorder, you know, often there's a lot of restriction. You know, people with binge eating disorder go from, you know, eating, feeling a lack of control around how much they're eating, and then going to, you know, very restrictive behaviors. So, you know, that's a cycle that is very, very common with binge eating disorder. And, you know, again, these are disorders that have very serious medical complications, and they also really take over a person's thoughts and, you know, really, really negatively impact their lives. But in terms of binge eating disorder, as I mentioned, it is more common than anorexia and bulimia combined.
I believe it. With, you know, people having like these yo-yo diets, you know, they want these quick, easy 10-day diets. You know, I'm going to lose 100 pounds. Yeah, it's not happening. You didn't, you know, it didn't take you 10 minutes to get those 100 pounds, so it's going to take you a lot longer to get those off. But, you know, with this yo-yo dieting, as you said, dieting is a risk factor for this, and you can start off innocent and once again spiral and take it to a whole nother extreme.
Yeah.
Joy, what is orthorexia?
It is a disorder that really kind of focuses on just the idea of clean eating, in short. And I think it's absolutely a newer diagnosis. And as we kind of mentioned, there's so many of these disorders that are in our culture. They are embedded. We are getting messages there. But it's the obsessive, the pervasiveness, the idea that I can't function in this world unless I'm eating at a certain rate or eating certain things. And so kind of taking it to the next level.
Absolutely. And I know that there's...
And we're hearing more about these kinds of cases from clinicians in the eating disorders field who are talking about patients who are presenting with this obsession around clean eating, or I need to only eat this particular type of food. And it's all, under this umbrella of I'm trying to be healthy. But
once again, starting off innocent.
Quite restrictive. Yeah.
Sure. Now, I know that there have been studies that also link it to obsessive compulsive disorder. Because I think they're trying to, that's why it hasn't been formal in the DSM criteria, is that they're trying to figure out if it's a standalone eating disorder versus is it just a form of OCD. What are your thoughts on that, Joy?
Well, I've definitely seen a lot of comorbidities, and having worked multiple levels of care, dealing with insurance companies and trying to explain eating disorders to them, it's difficult because there are so many things that we just don't know about these disorders. And again, these cases aren't coming up as frequently. I think the more that we are spreading awareness, the more that we are naming it and calling it out and letting people know that there is help for these things, people are coming forward, and we're then able to formulate what a good treatment plan could look like. But we're also not seeing a lot of orthorexia present. It is really difficult to get coverage there from an insurance standpoint, especially depending on the medical stability.
Yeah, because if there's no code, they don't want to pay it.
Exactly.
That's unfortunate.
Just really unfortunate. So we're working on it, I would say.
And I'm wondering, because I think they do cover this other category, which is other specified feeding or eating disorders, so they can probably put it under there until, because basically this is a catch-all kind of category. Is that not?
It is, and it's not uncommon at all for a lot of our clients from different levels of care to not just fit perfectly into one box. Depending on how long the eating disorder has been going on, it might be very presently one thing. However, they have a history of another and are a lot more susceptible to kind of going into a different eating disorder behavior.
Absolutely.
Yeah, and we hear this all the time from people who contact us through our helpline, and again, have often waited a long time to reach out for help, and will say, well, I'm not that sick, or, I haven't gotten this thin, and therefore, I'm not sure what it is I'm struggling with, and they might not fit neatly into one of those diagnostic categories. But that doesn't mean that they would not benefit from treatment.
Well, and you don't want to get to the point where you are that sick that we've got to hospitalize you because of this eating disorder.
Right.
Exactly. And again, early intervention makes a big difference. So the earlier you can reach out and get into help, the better.
Absolutely. And it probably helps with the relapse rate. We'll discuss that when we're talking about treatment options. But I can't imagine that it would not help with that. Now, there's another category called avoidant restrictive food intake disorder, because we've been talking about restrictions that are placed when you're anorexic or bulimic, and also the OSFED category. But we have a separate category that actually addresses just that. Claire, can you explain what that is?
Sure. And again, this is another eating disorder that we're hearing more and more about.
It's a new diagnosis, I know.
It is. Yeah. So essentially, when we're talking about ARFID, avoidant restrictive food intake disorder, it's what you would when you talk about extreme picky eating, but to a degree where it is very serious and affecting a person's health, and oftentimes there's an aversion to certain textures of food. It's really about that extreme pickiness and aversion to food.
Sure. And to kind of piggyback on what you're saying, this aversion is usually because they're trying to avoid a repercussion or a consequence. So perhaps they've had some food, small t trauma, or maybe they had some reaction that they're now trying to avoid, and now it's gotten to the point where they're not able to integrate those foods back into their diet.
And that makes sense. They're also linking this to like autism.
Yeah.
And other intellectual disabilities. Have you seen that, either of you, in your practices?
I have, particularly with our younger adolescents. And so this is one, when we talk about working with a team, we really need to get all the specialists involved. And so in treating RFED, we've oftentimes used occupational therapists to kind of work through some of the texture issues if they are present, working with GI, working with other consults as well. So we're attacking it from a physiological standpoint, but also a psychological one as well.
Yeah, and that comprehensive treatment team is so important for eating disorders generally, and certainly for RFID.
Absolutely. Now, this is one that was kind of new to me. You all maybe have seen it before, but bulimia, which is a diabetic who is restricting their insulin. And I haven't seen that, thankfully, because I know what the repercussions of that can be. But have either of you seen that and treated that before?
Yeah, we do hear about this a lot through the National Eating Disorders Association. We're not a treatment center, but we talk to a lot of people who are personally affected and families, and this is something that does come up. It's very dangerous, as you noted, but it is common.
Yeah. And in speaking of that, I mean, there is such a high need to educate endocrinologists on this.
Yeah.
Yes.
Just so that they can be looking out, and just like dentists should be looking for the erosion in the teeth, oftentimes our frontline medical professionals should be kind of looking out for these things so that we can intervene earlier.
Absolutely.
Yeah, and primary care providers as well.
Yeah.
So critical, and there's so little training on eating disorders in medical schools.
It's a blip in medical school.
And when you think about the prevalence, we need to have our providers better educated and equipped to recognize and refer when these cases are coming up.
Yeah, I agree with that. The primary care doctors, those are unsung heroes too, because they are frontline.
Yeah.
They see everything known to man, whereas I may not until they send, the patient to me. And so I wholeheartedly agree that there needs to be more training and more awareness that's brought to our attentions. And our medical societies need to be doing a better job of that as well. There is another disorder called rumination disorder. Can you tell me a little bit about that, either of you?
I can speak to that.
Joy, sorry, I missed the last part.
Oh, it's okay. I didn't want to try. I was like, I want to jump in if you're.
Okay, I can. You take it. I'll chime in. Sorry.
I can pass it along.
That's right.
But again, there's so many new disorders that we are working on, coming with evidence-based, best practice treatment for. And so rumination, it's really this involuntarily vomiting that happens. And so part of that treatment is trying to get down to the core issues. Is it really just a behavior of vomiting, and a lot of times we're consulting with GI. A lot of times they're presenting in GI before they get to an eating disorder facility.
Yeah, because you want to rule out other causes, like
Exactly.
is there a hernia, is there an ulcer? You want to rule out all sorts of other medical problems before you get to that particular diagnosis. So it may take a while before you all see that kind of patient.
Yeah. And we often see that comorbid with high anxiety as well. And so we're working to really treat every bit of it, the behavior of the vomiting as well as the root causes.
Absolutely. So those are the main ones, I think. Are there any other disorders that you've seen, Claire?
I mean, there's as Joy is mentioning, there's a range of ways that eating disorders present themselves, and you've run through some of the major diagnoses, but again, I would say a lot of times we see people who don't fit right into a particular diagnosis, and yet they still deserve recovery and still deserve treatment. And I think we also really need to talk about the need for more research. We need to better understand these illnesses and the interconnections, the comorbidities. Despite their increasing prevalence, eating disorders receive less than $1 in research funds per person affected. And that's compared to an average of $70 for other major mental illnesses. So, we really need more research to help us understand the roots of the illnesses, and also to develop more effective treatments. And that's another big area for us at NEDA is advocating for advancing research, because we know that there's a great need.
So as far as like treatment, because each of these obviously can't get treated the same way, but when you start treatment, you start with a phone call to an organization, right, to get you into a treatment facility. And how many treatment facilities do you know around the country are there?
Oh gosh, I don't know the exact number, but we do have resources at different levels of care. So I think when we are thinking about where to send somebody, let's say they're reaching out to the helpline at NEDA or one of the other advocacy groups that is really tasked to get people resources, we first need to look at the severity of the eating disorder, what medical complications, what psychological complications, what other comorbidities are coming up. And so when we look at eating disorder treatment, it spans from inpatient facilities that usually are dealing with the stabilization piece. And then we have residential treatment centers right underneath that. So that's kind of a place where we're able to spend a little bit more time psychologically stabilizing someone as well as medically, but we're really hoping to get them to a place where they can do the long-term work at lower levels of care. From residential, we have partial hospitalization, we have intensive outpatient programs, as well as just your outpatient teams, which would be your medical clinics, your outpatient therapists, seeing your outpatient dietitian. And what research supports is that those higher levels of care are pivotal in getting someone set up for success. And it takes about 5 to 7 years of good, consistent outpatient work and eating disorder treatment to have optimal recovery. So we're looking at a lot of different factors. So plugging in the different treatment options, I don't know if I can give you a number. I don't know if Claire can either, but.
Yeah, I mean, because of the different levels of care, it's hard to say. I mean, certainly there are a number of residential facilities across the country.
What I wanted to get at was the differences in the levels of care. So
Yeah.
Because when people call in, they basically get triaged off of that call into, okay, are you acute enough where you need to actually be admitted to the hospital versus can you come for an outpatient visit versus can you come to a residential and stay a while and then maybe to an outpatient facility. But who is on the treatment team in general?
You know, at our level of care at residential, and this is going to be pretty typical throughout eating disorder treatment, regardless of the level of care, we include first and foremost the client. I am really big on collaboration. We can't treat a person if we don't have their buy-in. We also include their loved ones. They're going to be the ones that are going to be supporting them. And so when we look at levels of care and criteria, we're looking to see how much monitoring they need. If they need 24-hour nursing, or do they have the family support to be able to talk through the issues that are coming up for them. So we have their families, we have their loved ones together. And then from a medical standpoint, it usually includes a physician, a psychiatrist, a psychotherapist, a dietitian, and whatever consultations we probably need to have, whether that be GI consults or working with OTs. It really can be any person, any provider that is wanting to kind of get at the whole person.
And you mentioned it takes about 5 to 7 years of treatment. Do we know the numbers for relapse rates, Claire?
We don't have really solid statistics on relapse, although we know that it does happen. It is common. One of the things we talk about with raising awareness and having people share their stories is a lot of times there's a tremendous amount of shame that comes with eating disorders generally, but certainly when there is a relapse. And we try to really send the message that this is recovery is not a straight line.
Ongoing.
It is ongoing, and a setback, a relapse doesn't mean that you're not moving in a forward direction generally. And we try to really connect people to support immediately so that they can get that that treatment they need, the recovery process going. But it certainly does happen. It's part of the recovery journey for many people with eating disorders.
Absolutely. And I know that we have packed a lot in an hour.
Yeah, we have a lot.
But I'm going to ask each of you to give me some parting words. Claire, you go first.
Well, I want everyone to know that recovery is possible. For our National Eating Disorders Awareness Week theme this year, we're encouraging everyone to come as you are. It's all about creating greater awareness and inclusivity in the eating disorders community. We really want everyone to, at any stage of body acceptance and eating disorders recovery, to join us in this campaign, which you can learn about at nationaleatingdisorders.org. We also have a hashtag for the week, which is Need Awareness, NEDA awareness. And we're also using Come As You Are. So participate on social media, participate online, and come as you are.
Claire, can you tell them how to reach NEDA?
Yes, we have a toll-free helpline. The number is 1-800-931-2237. And we also have trained volunteers on chat. So you can connect with our helpline through our website at nationaleatingdisorders.org.
Thank you. Yeah. Joy?
Yeah. I'm really excited. We have our NEDA walk here in Atlanta happening this weekend. And I have to share a brief story because a lot of people ask kind of how I got involved with just treating eating disorders. And honestly, it kind of fell in my lap. And I'm finding that the lack of diversity in treatment providers really is impacting how people seek treatment and how often they're coming. And so I actually was at a NEDA walk about 5 years ago, and it was my first one. And I was doing outreach, and there was one other African-American female who was there, and she came up to the booth where I was, and she said, "What are you doing here?" And I was like, "Well, I'm kind of working." And so I began to tell her a little bit because she was inquiring just kind of how I got started with eating disorders. And she was like, thank you. We at a walk of nearly 200, I don't remember specific numbers, but there was a lot of people there. We're the only African American women there. And to find that she was so impacted just by my willingness to show up really is what sparked me to continue going and continue speaking on this topic and informing people of the importance of just knowing what eating disorders are and what to do when they present in your office. And so I always kind of give a call out to clinicians. It's so important just to be open to the diversity and just kind of recognizing that the presentation can show up in any shape and form. And it's our duty to be able to accept that and to be able to recognize it. And so really challenging people to get educated on what eating disorders are and how we can really support the people that we're going to be seeing.
Absolutely. How can they find you?
Yeah. So I am full-time at Center for Discovery as a program director. Center for Discovery is a nationwide company. So we have over 60 locations that span over 11 states, and so they can go to centerfordiscovery.com. Even if you're not sure whether or not you want to seek treatment or whether or not you need residential care, there are free assessments that are no strings attached, just to kind of see where you are. So definitely check out centerfordiscovery.com. You will find our admissions team on there as well, and so we're happy to get you connected to where you need to be.
Absolutely. So eating disorders is not just a woman issue or a white issue or even a young issue. It's an everybody issue. Everyone is susceptible. If you believe that you have an eating disorder, please don't be ashamed. Get help quickly. If you believe that someone that you know has an eating disorder, don't be judgmental or accusatory. Let them know that you support them, you love them, and you're going to help them get the appropriate care that they need. A life depends on it. Please vow to make a difference in someone's life. So, do you want to find out more medical tidbits and become your own best advocate for your health? Go to my website, www.nationsbedsidedoctor.com, and sign up for my weekly newsletter. Also, you can find me all over social media. I have Twitter, Instagram, Facebook, LinkedIn. You can find me under Instagram and Twitter. I'm under Dr. T.M. Prince 4, and Facebook I'm under The Nation's Bedside Doctor at Dr. T.M. Prince 4. Please let me have a caveat with this Facebook, because I have been getting personal requests to my personal Facebook page. My business page is public, so you can go there and you won't have to ask me for a friend request, which I may or may not ignore.
Good to know.
Good to know. Until the next time we meet, have a great and blessed week. I look forward to hanging with you again next Thursday at 6 p.m. Thanks for tuning in to my show, The Health Tips with the Nation's Bedside Doctor, on Clark TV Network, where we believe in the future.
Help us give hope to those suffering with eating disorders. Belinda Myers used to weigh 220 pounds. Now she wears a size 8. What's her secret? Same as every dieter's secret. Within a year, she'll gain it all back again. Then go on another diet, lose weight, only to gain it back again. Till it doesn't matter what dress size she wears, because the dress she'll end up wearing only comes in one size.